welcome to all of you. Welcome to those of you for whom this is your first session at our Discovery Days this year, but welcome also to those of you who've been at everything yesterday and today, and I can see some faces of people who've done that. I think the Discovery Days are a fantastic opportunity for people, whether they're members of staff, whether they're students, or whether they're just members of the community in Dundee, to hear a lot more about some of the really exciting work that's going on in the university and some of the aspirations that staff have, and also some of the impacts that our staff have across a broad spectrum of research areas. The Discovery Days provide a great opportunity for individual professors to tell the community about their work, and they also allow our award-winning teachers and communicators to update the audience about everything that they do. The format for this is that the three talks will happen, and then we'll have the three presenters will be our victims in these seats to do a question and answer session at the end. And before I hand over to the first speaker, I'd also make the point to those of you engaging online that you could make questions available in the chat, and the colleagues here will pick those up and pass them on to me for when it comes the point to moderate that question and answer session. So, without further ado, I'm going to ask Professor Mike Macluskey from the School of Dentistry to come up and give us her talk about early detection of mouth cancer. So, thank
you. Good morning. I hope you can hear me. My name is Mike. I'm a dentist who specialised in oral surgery, and I'm based at the dental school in Dundee, a 5 minutes walk away, as shown here. So I'd like to just give you a very, very brief introduction to the kind of work I've been doing on the early detection of mouth cancer. And that's because many people don't know you can get cancer of your tongue, your gums, the roof of your mouth, the inside of your cheeks. So education is not great when it comes to mouth cancer. But unfortunately, almost 10,000 people were diagnosed with this disease in the year 2021. And that is approximately one patient every hour in the UK with that diagnosis. Now, traditionally, it's a diagnosis that goes to people who are of an older age group, above 55, and more men than women in a ratio of 2 to 1. And this is primarily because the most important risk factors for mouth cancer are smoking in all of its forms. So we'd be familiar with cigarettes, but it's the use of even smokeless tobaccos used as snuff, as chewing tobacco, as pan or areca betel nut, which is held inside the mouth for prolonged periods. So parts of the world have a much bigger problem with cancer than we have in the UK. But the worrying thing about mouth cancer in the UK is in the increase. There are more cases year on year and projected to increase year on year. And the sad thing about it is that it's associated with very poor 5-year survival because it presents very late because it's a silent disease. People don't know they have mouth cancer until actually generally it's very advanced. Now, not everybody that smokes gets mouth cancer. Other factors involved are alcohol consumption, which increases your risk, and smoking and alcohol together increases your risk by 30-fold. So in the UK, those are our risk factors, which are entirely avoidable risk factors. But not everyone who gets mouth cancer does either of those things. So we know diet plays a big part. Morbid obesity is a factor to play with it as well. And then the role of human papillomavirus has become more prevalent over the past decades in head and neck cancer in general, and a small subset of mouth cancers. So that might explain why we're seeing people in their 20s and 30s being diagnosed with mouth cancer. Now, we're getting better at treating mouth cancer, but because it presents late, the 5-year survival has not improved in decades, with more than half of our patients not surviving 5 years. In the year 2021, there were 3,000 deaths attributed to mouth cancer, and that's approximately one patient every 3 hours. So that's why this is interesting to me as a dentist. Now, most of these cancers are preceded by clinically detectable lesions. These are white patches, red patches, or painless ulcers, but painless. So most people don't know they're there, and most of us don't self-examine. So most of us don't actually look in our mouth most of the time. So then it falls to a screening for us to pick up these diseases, because if they're picked up early, they can be treated before they become cancers, which is the area I'm interested in, or when they're small cancers, when they're associated with much better 5-year survival. In the UK, we have no national screening programme for mouth cancer, and that's because only 5% of these obvious lesions in the mouth progress to cancer. So it's not economically viable to have a national screening programme. So screening occurs as an opportunistic thing when you go to your dentists. So I hope when you go to your dentist, you're aware of your dentist say, pop your tongue out, move it to the right, move it to the left. I'm going to have a wee feel at your neck. That's you having your screening done. And they should do it pretty much every time you go. But here is the problem. How many of us actually visit the dentist? It's estimated about a third of adults actually go to their dentist. And that's when the opportunistic screening takes place. So 2/3 of the population aren't getting that screening. The other problem is economics. People can't afford dentistry now, and I'm sure you're very aware since COVID, access to NHS dentists is becoming increasingly more difficult. So this problem is likely to become progressive. And then the other huge big elephant in the room is dental anxiety. How many of you here really look forward to that date in the diary with your dentist? Not many. More than 50% of us have anxiety about dentistry, but actually 1 in 5 of us, it's so extreme they actively avoid dentists. So for all of these reasons, this disease presents late and is associated with a poor prognosis. So what have I been up to since I've been at the dental school? So when I arrived 26 years ago, I did a PhD looking at what vascular does around precancers, which are called dysplasias. So I looked at normal tissue, precancerous tissues, the dysplasias, and cancers, and specifically looked at the blood vessels. For something to grow, it needs a nutritional supply. So if a tumour can stimulate blood vessels, it will allow it to grow and it'll allow it to spread. So that's what I did for my PhD. And what I found was blood vessel density associated with the transition from normal through precancerous to cancer increased. So something was stimulating the vasculature. One of the commonest vascular stimulators is a molecule called vascular endothelial growth factor A. And we found it was upregulated, so the cancer cells were producing this to stimulate the blood vessels to grow. And we looked at one of the inhibitors, one of the commonest ones called thrombospondin 1, and we found it was downregulated. And that makes for an interesting story about how the blood vessels developed. But mouth cancer doesn't use blood vessels to spread like a lot of other cancers does. It uses the lymphatic vessels, so it'll spread from your mouth to the glands in your neck, which is why your dentist feels your neck when you go to the dentist. So I wanted to know, could it stimulate the development of these vessels as well? And these are called the lymphatic vessels. And we found the lymphatic vessels also increased from normal through dysplasia to cancer. So that made for an interesting starting point. So my first PhD student came along, actually she was a master's student to start with, and she took this a wee bit further. So she got the same model, normal, dysplasia and cancer, looking at blood vessels and lymphatic vessels, but she looked at the matching tumour tissue and also the blood from the patients. So they drew blood from patients and we could map that to whether or not a blood test could indicate which cancers behaved more aggressively. So she found the same as me. So increasing in blood vessels, increasing in lymphatic vessels, driven by increased expression of the stimulator VEGF-A and decreases with thrombospondin. She also looked at a molecule VEGF-C, which upregulates the lymphatics, and she found that significantly increased. And then in the blood, VEGF-A, VEGF-C, VEGF-D, which also regulates and upregulates the lymphatics, all increased and thrombospondin decreased. And VEGF-A and VEGF-C were significantly associated with poor prognosis. So that was where we started. Now, I mentioned that human papillomavirus is associated with a small subset of mouth cancers. So in 2008, my first PhD student, Termidi, came on board, and at that point, we were using a surrogate marker called P16, which is a protein which is expressed in HPV-positive cancer cells. So we stained all of our head and neck cancers looking for evidence of this. So Termidi wanted to know how many of our mouth cancers had HPV, what type of HPV it was it the low-risk type that wasn't associated with cancer or the high-risk type that was? And he found that in his sample overall, 58% of all our mouth cancers had some form of HPV. We found 15 different types of HPV, and sometimes the cancer had more than one type of HPV. But we wanted to know, could P16 identify the 25% that were high risk? And only the high risks were positive for P16. What we tended to find was P16 was positive for a lot of tumour tissue that wasn't HPV positive, suggesting that we had some false positives. Termidi finished in 2011, and then my next PhD student, Athiva, came on, and she took this to a mixed sample of head and neck cancers, oropharyngeal, which is tonsil and base of tongue, mouth cancer, and laryngeal cancer. And she also found, specifically only looking for the high-risk types of HPV, that 25% of her cancers had high-risk HPV. In the mouth, that was only 17%, but in the oropharynx, which is the back of the tongue and the tonsil, 71% of them were positive, and all of them were P16 positive. And the other marker we were looking at was a thing called EBP50, which disappears when you've got HPV positive cancer cells. And we found that the EBP50 disappeared. So as surrogate markers go, P16 and EBP50 might be useful, but maybe not in isolation because of the false positivity rate. Huda, my master's student, came back in 2015 and she wanted to do a PhD, but now she was interested in what made nerves grow, what made the tumour cells grow along nerves. So in this, I don't know if you can see, this is a nerve fascicle and it's surrounded by a sleeve of cancer cells. And these cancer cells use the nerves, really it's almost like a highway, to disappear to different parts of the head, particularly intracranially, and that was associated with poor outcomes for our patients. So she looked at one of the factors that stimulates not just nerve growth, but she was interested in whether it stimulated the growth of tumour cells, and that was imaginatively called nerve growth factor. And she found that nerve growth factor was upregulated in those tumours that had perineural invasion, as was its receptor. And perineural invasion and increased expression of nerve growth factor was significantly associated with a poorer 5-year survival. She did matching cell cultures studies where she added nerve growth factor to cell cultures of cells of oral cancers and salivary gland cancers, and found that nerve growth factor causes scatter of the cells and increased motility of the cells. So it would seem that this nerve growth factor actively allowed tumour growth, facilitated tumour growth. Now, my colleagues at the dental school, the clever ones, they've been studying a cell signalling pathway called PI3K-AKT, which is a very important pathway in tumour cell progression. By binding to the receptor on cell membranes, a number of molecules can activate this pathway, which is associated with increased cell turnover, decreased programmed cell death or apoptosis, increased cell motility, and also vascularity, angiogenesis, the formation of new blood vessels. So it's really a very important cell signalling pathway in cancers. So we had a PhD student called Mo Islam, who's now a member of staff. He initially looked at my sample of VEGF positive tumours and found that VEGF attached to this receptor and stimulated the AKT pathway and was associated with poor prognosis. Huda, who did the nerve studies, also looked at this pathway and found it was upregulated with nerve growth factor. And the work we did with HPV we found an inverse correlation with this particular pathway. And then a most recent PhD student, Bashir, was looking at transforming growth factor beta and found it also upregulated this pathway. So looking for biomarkers going forward, this would be an important pathway for us to follow a bit more. Now, for the past 16 years, I've had a weekly clinic dedicated to patients with white patches, red patches, for the early diagnosis of potentially malignant lesions. You can't tell by looking at someone's mouth whether their lesion is one of the 5% that goes on to become a cancer. So all patients have to have a biopsy, which is invasive and uncomfortable for patients. So if someone offered me a detection kit that avoid an invasive procedure, I'd be very glad to try it. And that's what happened in 2015 when a group based in the Netherlands and Belgium asked if we would trial this laser detection system that they had been developing for the early diagnosis of esophageal cancer, and could we use it in the mouth? So that's what we did. It was a nice wee system. It was quite portable, and it had a camera system so that you could take serial photographs of the lesion that you could superimpose to look for signs of change. So it looked as if it had quite a lot of potential. And what we found was, using the laser system, you could work out what was cancer and what was normal. But the bit that I wanted, which is the precancerous lesions, it couldn't discern which ones of these were the ones that were the high risk with the higher potential. So sadly, we didn't take that further forward. But more recently, I've been working with my colleagues in the School of Engineering, Dr. Lee's group, and she's been looking at the use of optical coherence tomography and angiography for the early detection, and they used it on skin cancers and found it quite useful. That's an understatement, quite useful. But we wanted to see if we could use it inside the mouth. So one of her PhD students, Thomas Zhang, he's been mapping out what's normal. And what interests me about this is it ties back into the angiography. because this allows you to look at the actual histology of the mucosa. That's the superficial epithelium, the top layer, and this is the material underneath where we find the blood vessels. And then you can actually see the blood vessels within the tissues, and it does it in 3D real time, so you can scroll up and down to a depth of 1.7 millimeters. So what we're hoping next is to take this to a clinical trial where I can use this on my patients to initially screen their mouths to see if there's areas that absolutely need biopsied, and also to use it to monitor for recurrence. So be interested to take this forward. Other things that we're doing just now, I have another PhD student, Himani, who's doing a retrospective review of the last 20 years of the management of these pre-malignant lesions, which is what I've been doing. And I want to know, when I take away these lesions, how many patients get recurrent disease? Because we know that they do. Even when you take it out in its entirety, it doesn't guarantee cure. So I want a subset of patients who have had recurrent disease, a subset of patients who've gone on to develop cancers, so that we can then take that information to the lab and do biomarker studies. Because what I'd really like to be able to do is personalise the risk assessment for a patient, so I can inform the patient more realistically what their risk is of going on to develop mouth cancer. So we've got 2 PhD students starting in September doing some biomarker work based on the findings of past 16 years of my clinical work and also the past 20 years from Himani's PhD. Now, all of the work I presented is single site studies, which are generally underpowered because they're not large samples. What we really need to do is collaborate in multi-centre studies. So I was delighted to be invited by a group based in King's who've developed a quantitative malignancy index diagnostic system, which is a bit of a mouthful. And this only needs 1 millimetre of tissue to then screen for 16 potential biomarkers. And they've been piloting and showing that it actually correlates well with lesions that progress to cancers. So we're in the process of trying to secure funding to then develop this at 10 sites throughout the UK. Now, I know over the past 16 years, when I tell patients they have precancerous lesions, all they hear is cancer. That's what they come away with. I've got cancer. And it's really difficult to try and persuade them they haven't got cancer. We've caught it really early. It's the stage before cancer. So I see a lot of anxiety amongst our patients. So I'm particularly interested in how we can help patients and support them with the anxiety. We did a small study and we found that 48% of our patients reported moderate to high levels of anxiety of a diagnosis of a precancer. So next week, one of my PhD students is starting a qualitative study to see if we can understand this anxiety more and possibly develop some kind of, I don't know, facility to help support them. And she's going to start that next week and hopefully we'll take that forward. So it's quite obvious that I've not done this in isolation. There's been lots of people helping me over the way, often many people far more clever than me, and I'm very grateful for their support, from my PhD supervisors to all of my students so far. I'd like to thank the funding bodies, because it's actually really difficult to secure funding for this cancer because it's the 10th commonest cancer in men in the UK. So there's lots of other cancers that take priority, and single site studies are difficult to get funding for. So I'm really enthusiastic about doing multi-centre studies. I'm very grateful to Tayside Tissue Bank, who've supported all of the work that's been from human tissue. And I'm just about to finish, because I'm going to finish by thanking my family for their love and support over the years. I'm delighted my sister Bernie is here today. Bernie has been very supportive, particularly financially at the end of the semester when I was always skint as an undergraduate. I'd like to acknowledge the love and support of my husband David, who has been my strongest supporter over the years and has never given up, has always believed in me. So now that I've embarrassed my family, my job here is done, and I'd like to thank you for your very kind attention. Thank you.
Thank you very much, Mike. That was a fascinating talk, and really clear as well, which to a layperson like me was a big bonus. I do despair when I see these English Premier League footballers with the snooze things under their lip. God, you know, let's not have that come to the UK. I think it's too late though, eh? Okay, so our next speaker, we'll plenty of questions for Mike later, but our next speaker is Professor Graham Rena. Graham is the Chair of Cardiovascular and Metabolic Medicine in the School of Medicine. I did have to read that, and he's going to talk to us about second lives for existing medicines. Thank you very much. Thank you.
Okay, so I'm going to start by thanking my family, embarrassing them because in case I forget at the end, in case I get carried away, so I just want to thank my wife, Michelle, who has been the support through 20, 30 years of academic research. Thank you very much. And thanks to all the rest of my family too. I also want to talk to you about some of the, acknowledge straight away some of the really fab scientists who have been in my lab over the years. I'm going to talk today mainly about the last 10 years of my research that's led to my chair, but you know, I've had some really fantastic scientists through my lab for more than 2 decades, so I'm going to thank them all at the end in an acknowledgement slide, but I particularly just like to single out Rena, who's on the left there, who is in my lab at the moment, a postdoctoral research scientist from Iraq. We have Noor Al-Qurashi in the middle picture there, who's a PhD student from Saudi Arabia. Erica Gutierrez-Lara, Dr. Erica from Mexico. At the back there, we have Magdalena Sobakova, who's a very talented new PhD student in the lab, and Dr. Ian Fair, who's a postdoc who recently left the lab. So those are the people whose data I'm going to be mainly talking about today, and I'll introduce more people as we go through the story. But I want to unpack my title first. It ain't over till it's over. So that's a saying from the famous Yankee baseball player Yogi Berra, who went on to be a sports pundit in his later life. And there was a good analysis of one of his, I guess these sports pundits are very quotable. There's good analysis on the BBC website of his most famous quote. And it's a tautology, it doesn't mean anything, but it reminds you that there's still hope, okay? So that's why that's in there. That if you wipe the sweat from your brow, spit on the ground, and come out fighting, there's still a chance of triumph. I think that's a really good philosophy for an academic career. And also, it's also a Lenny Kravitz song, okay? But those 2 reasons, neither of those 2 reasons are the reasons that it's in my title. The reason it's in my title is because I'm talking about second acts for ancient medicines, which we also call repurposing, okay? So most medicines designed nowadays, probably for the last, I guess, 60 years or so, are designed deliberately to a known target, okay? And that's thanks to the pioneering work by this guy, James Black, who was Chancellor of this university until 2006. Okay, so that was exceptional pioneering work that established the bedrock for all modern drug discovery, okay? But what we also have, any pharmacist or clinical doctor will tell you, we have a lot of older medicines that were found by accident, and many of these are amongst our best medicines, actually. But they were found by chance. We simply don't know how they work, okay? And that's where my research comes in. So my research is involved in finding out retrospectively how those drugs work. And if we can know more about them, then that means potentially that we might be able to use them more effectively. We might be able to identify patient groups who will respond to these drugs that we're at the moment only using in sometimes quite isolated patient groups. So I'm going to tell you today about repurposing of old medicines, metformin, salicylate, and colchicine. Okay. So I'll tell you first about repurposing of metformin for cardiovascular disease. And I'm sorry, Amy, I'm going to embarrass you because you're in the audience. So this is work by Dr. Amy Cameron, also Dr. Callum Forteeth, who's looking very young in this picture. I guess this must be almost 10 years ago. And also Pradeep Mohan, who was in Chim Lang's laboratory at the time. So research on metformin goes back at least a century. It's the top-line type 2 diabetes drug, but how it works is unclear, okay? So what Amy identified was that the drug has anti-inflammatory actions, and we found that this occurred irrespective of diabetes status. So I've underlined that because it kind of sounds not really that important, but it is important. because it means that in terms of clinical potential new uses, it means that metformin may be repurposed into non-diabetic patient groups, okay? And so how do we do this research? Actually, the medical school is probably one of the best places in the world to do this kind of research, because we have outstanding non-clinical science, but we also have almost second to none, I would say, patient records, okay? And that's actually a credit to NHS Scotland, okay? So it all comes down to this thing called the CHI number. So everybody in Scotland has a CHI number, which is just a patient identification number, okay? And all of your patient data, every time you go to a GP, every time you have a medicine prescribed at a pharmacy, or you go to a cardiology clinic for an echocardiogram, or you diagnose with diabetes, all of that's integrated into your CHI number, okay? And that means that we can analyze anonymized patient data on a very large scale, and that gives us a very high statistical power to, if we have an idea that we've developed in bench science, to then ask the question, is that relevant to people? Because ultimately, if we find something in a cell, in a lab, it's not really going to be that interesting to us unless we can demonstrate that it's relevant to human beings. And that's really what we can do in 9 wells. It can't really be done so well, I would argue, anywhere else. I just want to give you, I don't want to give too much data today, okay, because I guess I'm trying to have this as a sort of a lay seminar. So I've got one slide from Amy's paper on the left here. We have a Western blot, okay? So this is effectively looking at inflammation, okay? So if you look at panel B, okay, so this is what metformin should normally be doing. So metformin in panel B is regulating metabolic signaling. So it's a diabetes drug. We expect it to have effects on metabolic signaling. But what Amy's insight was that it also has effects on inflammation, okay? We didn't expect that to happen, but because we're in 9 wells, in real time, we can see if that translates to human beings. We can ask the question, is that inflammation detectable in human beings? And in collaboration with Jim Lang's group in 9 wells, we established that yes, it does. To cut a very, very long story short, we found that patients given metformin compared to patients given another drug, there was an anti-inflammatory effect looking at a biomarker called the neutrophil to lymphocyte ratio in these patient records that I told you about. Okay, so this research got the Circulation Research Top Manuscript Prize in 2016. So that's, I guess, the second biggest cardiovascular research journal, and a diabetologia review that followed from that in 2017 has been downloaded over 100,000 times, which I suppose is my biggest taste of scientific superstardom so far. Okay, so that's metformin. So I guess that's what I've made my name in. But we've also recently been studying salicylate. So this is another drug that we potentially might be able to repurpose for diabetes. So it's obviously used for analgesia already. It's research into substances from willow bark that are salicylate, goes back to Egyptian times. So this is the Abus papyrus. There's another local connection, okay? So these are the discovery lectures. So there's also the discovery walk in Slessor Gardens. If you have time one weekend or one evening in the summer, recommend you go down there and you can have a look at Thomas McLagan's plaque, okay? So he was a clinician in the 19th century, and he studied salicin, which is a derivative of salicylate, which is found in willow bark, okay? So, and we also have, of course, Professor Graham Hardy, who's done a lot of work in life sciences on salicylate more recently. So there's been a lot of research going on in Dundee to try and use salicylate more in more patients. It's also the active ingredient of aspirin, but we're interested in diabetes, so the action on diabetes is not well understood. Okay, so why are we interested in salicylate? There's loads of diabetes drugs already. Why do we need another one? Okay, so many type 2 diabetes drugs were identified in trials in white older people. Okay, so they're really good drugs for that patient group. But what we're finding is that medicine failure of some of those drugs, not all of them, is higher in young people and ethnic minorities with type 2 diabetes. And so this really ties in with the triple intensity of the University of Dundee strategy. We really want to have research that has impact in people's everyday life. So that's what we're aiming for here, is to have medicines that will be useful potentially to narrow health inequalities. So how might this work? Okay, so generally type 2 diabetes is treated by increasing insulin amounts or making it work better. Okay, so you've got some drugs that act on the pancreas on the left there, or insulin itself can be given. So the drugs either increase the amount of insulin being secreted by the pancreas, or you can give insulin itself. So you'll increase the amount of insulin. Or you can have drugs that will act on the tissues that insulin acts on, such as the fat depots or the liver, and they'll make insulin work better. Okay. But what we think is happening in these groups that maybe aren't so well served by the existing medicines is that these targets are actually not optimal. Okay, all type 2 diabetes is not the same. Okay, but it's predominantly all treated the same way at the moment. We have SIGN guidelines, we have NICE guidelines that everybody will go through the guideline and in the same manner. Okay, so the thing that we're interested about salicylate is it has an action on muscle that may be particularly useful in these currently difficult to treat groups, and that's what we're working on at the moment with RAID. So how are we doing that? Okay, so we're finding the needle in the haystack. So if we're trying to find out how a drug works and we don't know how it works, then we're looking for a needle in a haystack, okay? So there's this method that we're using called proteomics that allows us to identify, we look in a cell and we identify all of the proteins that are changed by a drug that we treat the cells with. Okay, so we're looking at muscle cells here because we're interested potentially in salicylate as a muscle insulin sensitizer. It's a really rapid technique. It can tell us every single protein in the muscle cell. So we get the answer out straight away. That's really exciting. We want to know how the drug works. It's taken people a century to work out how this drug works, and we can find the answer straight away. But we need to have the wisdom to actually make sense of the data, because we've got, as I say, these hundreds of potential targets, okay? And I think RAID's brilliance has been that in 3 years, he's taken these hundreds of proteins and he's narrowed it down to potentially one. We think we have identified the key target of salicylate for diabetes, and we're just working on writing that up just now. Finally, I want to talk to you about colchicine, which is the third drug that I'm telling you about today, which is potentially another wonder drug in the making. It's isolated from colchicine. It's isolated from crocuses, I should say, and it's an ancient anti-inflammatory medicine used in gout. Okay, and this is the work that Magdalena's been doing. It's got cardiovascular benefits. Okay, so there's been some trials recently showing very good cardiovascular benefits of these drugs in myocardial infarction and chronic coronary disease. But like the other drugs, we don't know how those effects are happening. And so we're studying this again using proteomics. And I've got a slide here just explaining the advances in proteomics that there have been recently that are allowing us to do this research. And this is not my work. This is Dougie Lamont, who's, anything you want to do about protein identification, he's the man. Okay, so historically, looking at the top of that figure there, you would have you would have basically screened out all of the proteins in your sample. You would have just been aiming for a single sample. You would have just been aiming for a single protein that you were interested in, because the detection that we had historically wasn't very good. Now, with the advances that we have in detection, you can identify all of the proteins in a sample at once. Okay, so for the kind of research I'm doing, that DIA approach, so data independent acquisition, where you identify all of the proteins in a sample at once, is absolutely crucial because it allows us, as I say, to identify the targets very quickly. Magdalena's lucky in a way. She's identified only 32 serum proteins regulated by colchicine, and we found that 29 of those are regulated by a single liver enzyme. So we think we've also identified the target of colchicine, and we're just preparing a manuscript on that. Okay, I see I've got 1 minute left, so I just want to thank a few more people. There's a great bunch of collaborators in the medical school. I'm going to embarrass Rory because he's here. I just want to thank Rory for some outstanding leadership in the last few years in the medical school. I want to thank Philip Cohen and Miles Housley for giving me my start, and John Peters for helping me out when things weren't so peachy, also the Kuwait International team for the same reason. And I want to thank all of these funders as well who've supported me over the years. Thank you very much.
Thanks very much, Graham. Another really accessible talk on subjects that I think are very close to so many people. So that's been really helpful, and I know there'll be questions about that when we come to the Q&A session shortly. So our final speaker in this session is Professor Marcus Lee. And Marcus, I will read it again because I'll get it wrong, is the chair of Parasite Molecular Genetics in the School of Life Sciences, and he's going to talk to us about gene editing as an approach to antimalarials. Yep. Thank you.
Thanks very much, and welcome everyone. And it's really exciting for me to be here today to tell you about our work on malaria, and particularly the problem of antimalarial drug resistance. So when most people think of malaria, they tend to think of one or two things, depending on your inclination, either mosquitoes or gin and tonics. The mosquito, of course, is somewhat unwitting accomplice in this whole thing. It's the only way, though, for the parasite to get out of my blood and into yours. Sort of a flying hypodermic syringe, effectively. And it's true, if you were to kill the mosquitoes, you would block transmission of malaria. But we also need safe and effective antimalarial drugs for when the patients come into the clinic, because at that point, the mosquito is long gone. And coming back to the gin and tonic, quinine in the tonic water was perhaps the first widely used antimalarial. And it's what the bitterness of quinine is ostensibly why we put the gin in, to make it more palatable. Modern day tonic water has a lot less quinine, so you literally need to have liters of gin and tonic a day to have any protective effect against malaria. So do what you will with that information. All right. So we studied the malaria parasite, the Plasmodium parasite. I'm going to stand over here just so I can see the slides. And so it's not a virus, it's not a bacteria, but it's a eukaryotic parasite. And so that means it shares many of the same genes, many of the same cellular structures, in fact, with us. And that actually makes it harder to make drugs that kill it, because you always have to worry, of course, that when you're hitting those targets, if they're shared with us, you also might inadvertently hit the same targets in our bodies and have side effects. And so that complicates drug discovery efforts for Plasmodium. Despite some of the similarities, in fact, the parasite is a very complicated life cycle, which I won't try to explain to you. But at least in this stage, it has some, oops, beg your pardon. At least in this stage, it has some unique structures which help it to do one of the things it does really, really well, which is to get out of red blood cells and back into, oops, red blood cells. Okay, there we go. All right, so you can see here some parasites that have just burst out of a red blood cell, and within seconds, this movie is almost in real time. They're finding adjacent red blood cells which they bind to and attach and start to invade. And so they're really out there in the circulation system, exposed to the immune system for a very short time, for really seconds, and then they're back safely ensconced in another red blood cell for the next 2 days, where they then develop and replicate. So the opportunity for the immune system, at least, to kind of see these parasites is very limited, and that's again why it's really useful to have drugs that can kind of penetrate into those cells. So I guess first the bad news. The bad news is that we still have over 200 million cases of malaria a year, over 500,000 deaths, many of those in children. But I guess the good news, at least with a long, wider lens, is that malaria has been eliminated in some parts of the world over the last century. And so particularly if you look at the sort of yellows and the oranges, that's where malaria has been eliminated over several decades ago. And those advances were really built on a few different pillars. One was the widespread use of really effective insecticides. So DDT was released in the 1940s. There was also draining of swamps and marshlands, of course, of the malaria, the mosquitoes don't breed. And there was also the other pillar of new and really effective antimalarial drugs like chloroquine. And there was a point in time around the 50s where there was actual optimism that malaria could be eradicated potentially from the world with all of these tools. But that those pillars really started to fail. And so the widespread use of insecticides like DDT became untenable. And drug resistance to some of the what in my book is one of the wonder drugs of medicine, which is chloroquine, also became a huge problem. And so chloroquine was released, was starting to be used in 1946. By 1958, the first inkling of resistance occurred first in Southeast Asia, and then independently resistant parasites arose in South America. And really over the ensuing years and decades, drug-resistant, chloroquine-resistant parasites were found pretty much wherever malaria was found, really compromising the effectiveness of that drug. And that movie has really essentially been replaying itself again and again in one form or another. With every new antimalarial that goes out there, the parasites eventually, at some speed or another, become resistant to them. And in fact, the time between when they're released, when the antimalarial is sort of first deployed, and when resistance occurs, can be actually quite breathtakingly short in some cases. And so I feel like as long as there's malaria in the world, we will always need new antimalarial drugs that work in novel ways to keep up with the evolution of the parasite, with the evolution of drug resistance. So again, the good news is that over probably the last 20 years or so, there's been really concerted efforts both from industry like Novartis and GSK, but also academic groups, in particular here at the Drug Discovery Unit here in Dundee, to screen antimalarial compounds and identify newly acting antimalarials. And so, in fact, there's a really fantastic story here at Dundee by the development of cabamaquine, which is one of the next generation antimalarials that's currently undergoing late-stage patient trials. And so collectively, between all those efforts, there's probably been about 8 million compounds that have been screened for their ability to kill the malaria parasite. And there's literally thousands of these compounds that could kill the parasite. So the question then becomes, which of these are acting in new ways and novel ways that are not subject to the resistance mechanisms that are out there in the field? Because what we don't want is to find a new antimalarial that is already going to be compromised by resistant parasites that are there already. So we need to find them, ones that act on new mechanisms. And so one of the ways that, at least in our lab, we do this is not proteomics, the way Graham just talked about, but by using genomics approaches. And so I'm kind of going to illustrate one of the pathways that we take in the lab to try and identify what the targets are of these candidate antimalarials, and also understand the ability of the parasite to resist them. So, because again, we want to find new compounds that the parasite finds it very difficult to generate resistance to. And so the approach we take is sort of quite simple in some ways. We take one of these compounds that we know kill a parasite, but we don't know what the target is. And then we try and elicit resistance in the lab. We try and evolve resistance. So these are our malaria parasites growing here in red blood cells. And we can kind of gently coax them with increasing amounts of drug and try and get them to evolve resistance. And sometimes they can take weeks, sometimes they can take months. Sometimes it never happens at all. And actually, that's quite an interesting result too. But when they do evolve resistance, when we can sort of see them now becoming much more able to grow in the presence of drug, we can try and identify what's changed between the parasites before we tried selection and after we put the selection pressure on. How have they evolved? And so we can do this by sequencing their genome and looking for any new mutations that have arisen. And typically there might only be one mutation that's driving that resistance, and there may be a sprinkling of other mutations that are just kind of there in the background that have arisen randomly. And so to really kind of nail what the mutation is, what the mechanism is, and really what the target, ultimately that's what we want to know, is what the target of that chemical compound is. How is it killing the parasite? To really nail that, then we use genome engineering, so this approach called CRISPR editing, which some of you may have heard of, and that allows us to make very precise cuts at very precise points in the genome. And essentially what we want to do is transplant that single point mutation into a parasite that's never seen drug before and ask, now, is that parasite protected? Just by introducing that one point mutation. And so again, we can measure that in the lab. So these engineered parasites, and essentially you need more drug to kill them. And if you do, then that tells us that that point mutation is what's driving resistance. And then lastly, what we've been doing with these collections of resistant parasites that we've been generating in the lab is to barcode them. And I'll explain what that is and why we want to do that over the next few slides. And so the concept that this approach has actually worked really well for us. A lot of other groups in the field have been using this, and it's very successful. But one of the problems, in fact, that we have is that there's an increasing tendency to find the same usual suspects again and again. So the parasite has 5,500 genes. We know from various genetic studies that there's probably at least 1,000 of those, 1,000 potential targets, if not more, that are essential for the parasite to grow. And yet, many of the times we're hitting the same targets and again. And there may be reasons for that. I'm not sure I know the answer to why that is really. But it's a problem because we don't want to keep finding the same targets again. We want to as diverse a possible panel of targets as possible. And one way to illustrate this is a screen of what's called a malaria box, which is a very small library, just 400 compounds, but chosen for the chemical diversity. So potentially they should be hitting lots of different targets. And when this was assessed for how they act, out of those 400 compounds, 28 of them hit this target called ATP4. So 28 diverse chemical compounds all hitting this one target, which is a sodium transporter called ATP4. And that kind of story is similar. There's a number of other targets that fulfill that too, that they just keep coming up again and again. And so how do we avoid that? How do we triage compounds that hit known targets? How do we enrich for ones that hit new ones? So one approach, which we and many others have used, is essentially to look for something called cross-resistance. And so the idea is this: if you have this chemical compound number 1, which you kill the parasite, and let's say you select for resistance and you get resistance in ATP4. Okay, so you know how that's working. Then you take compound number 2 and you try and challenge these mutant parasites with compound number 2. And if that parasite is also resistant to compound number 2, that tells you that compound number 1 and compound number 2 are acting on the same target, or acting by the same mechanism. Then you can take that same parasite and challenge it with compound number 3, compound number 4, and compound number 5, and so on and so on and so on. And every time they act against, every time that resistant parasite that's resistant to compound number 1, let's say it's got a mutation in this gene, ATP4, is resistant to some of these other ones, that tells you these other compounds are probably acting through the same pathway. And then you sort of do that with ATP4, and then you do it with the next target, and the next one, and the next one, and so on. And so you can sort of see this works, but it's a very slow and laborious process. And so we were trying to think of a way to kind of short circuit that and test them all together at once. And so the approach we came up with kind of bears some hallmarks, or is reminiscent, I suppose, of the same problem you have on a Saturday morning when you go down to Tesco and you do a big shop for the week, and you end up with this diverse shopping trolley full of very many items, which you want to categorize, you want to count. And the one thing, of course, that you're familiar with, because you do this yourself, is you do barcode counting, because the one thing that unifies all of them, no matter what they are, is they have a unique identifier, a barcode. So then hypothetically, if you wanted to see which of your items in your shopping trolley were fire resistant, you could take them one by one and you could set them alight, and you can see how quickly they burn. But a more effective method would be to just pour kerosene over the whole thing, set it alight, and then count the barcodes at the end. And what you'd probably find is all the barcodes at the end would be things like the baked beans, cans of soup, etc. And that's you could essentially test them all at once. And of course, this is an analogy, but in this analogy are various drug-resistant parasites, so the items in the shopping trolley. The fire is an antimalarial compound, and the barcode is well, it's the barcode. And so it's a short, in our case, a short, unique genetic sequence, a unique DNA sequence that, again, we use CRISPR engineering to drop into the genome of each parasite, essentially tagging each parasite with a unique identifier that we can count. And so the approach that we've developed then is we call it the antimalarial resistome barcode sequencing, or ARIBA for short, just because it rolls off the tongue a lot easier. And here then is the idea that we have a diverse library of different parasites, including some of these usual suspects like ATP4 and others. And then we sort of pool them together, because now they're all tagged. We can just count the barcodes. We can mix them all together. We don't have to test them one by one. You can pull them all together, put them through the crucible of the antimalarial challenge. And if they all die, well, then we know that antimalarial is working in some novel way that's not represented in the pool. So that's potentially really interesting. But if just one or two of them do survive, and then those will be really enriched, everything else will die. these survivors, these winners from that challenge, we can read off the barcode using, in this case, next generation sequencing, which is just like a glorified barcode scanner in our case. So that's the idea. So just this is my one piece of data that I'm going to show you. And so this is sort of how it works in practice. And so you don't need to be familiar with these bar charts to really understand what I'm showing here. But essentially, each of these bars here at day 0 represents the abundance of a different parasite in the pool. So these are the barcode abundances. And you can see at the start of the pool, we've made a mix of parasites. We have about 50 or so in our mix at the moment, 50 different drug-resistant parasites. And when you hit them with this drug, in this case, in this experiment, this compound here called GNF179, when you hit them with a low amount of drug, not much happens. I mean, some go up, some go down, but it really doesn't change too dramatically. But when you hit them with a medium concentration of drug, or even a higher concentration of drug, you can see something very dramatic happens. That complex pool clarifies very quickly down to just 3 or even just 2 barcodes. And then when we scan the barcodes, we know exactly what parasites they correspond to, and they all have mutations in a parasite gene called CARL. And so if you didn't know how that compound was acting, within 2 weeks, you would very quickly know that that's acting on this one particular target. And so now in my last slide, just to say, we don't want to do this as 1 or 2 parasites, 1 or 2 compounds. We want to do this potentially with hundreds, thousands of compounds. And so we had a grant from the Gates Foundation to help us try and scale up our throughput. And so this is work actually that Rachel Coyle in the lab has done a fantastic job trying to get running. And so she's firstly miniaturized our culture. So we grow the parasites in red blood cells. And we've gone down from 10 mil culture flasks, they're called, down to 200 microliter tiny cultures. And then we can array those in these 96-fold plates. And that opens up then the possibility of liquid handling robot automation. And so Rachel, again, has really got this working with this robot in our lab here. She's written some scripts that essentially tell it to help feed and change the media on each of these cultures so that a person doesn't have to do it and spend hours in the culture manually doing this. And so each of these little wells is a different compound being tested against our library. And so currently screen about 500 or so compounds, hoping to do a couple of hundred, if not more, over the next few months. And Mary, who's sitting in the audience here, is looking at me like, that's a lot of compounds, and she's going to be the one that's going to be doing it. So just to finish then, I want to thank the lab in particular, and so no prizes for guessing when this photo was taken. And so I just moved my lab here to Dundee last year. I have a really great group of people, and some of them are here. But I want to highlight particularly Rachel and Mary and Top and Adam, all of which have contributed some aspects to developing the assay and getting it up and running and further developed here. And also Hannah and Manuela at Sanger, where I was. And I just want to thank you for your attention. Thanks very much.
Thank you very much, Marcus. Another fascinating talk and another very important disease that we need to tackle in the world. So that's fascinating. Excuse me. So could I ask our speakers, please, to come out now and occupy these 3 chairs, and we'll start to take some questions. So up there first, I think. Thank you.
They were all really fantastic talks. Thank you. Mike, I have a question for you of whether there are genetic signatures that are associated with these different mouth cancers, or are they really all sporadic that arise just because of the mutational effects of smoking and mouth challenges?
So most of the research suggests there are 9 molecules or genetic mutations associated with head and neck cancer. So for the vast majority of them, you could do genetic screening, but we don't routinely do that for patients. But I think that if you were wanting to do a study, that would be a really important area to screen our patients to understand a bit fuller. But 9 molecular mutations have been found within mouth cancers, specifically mouth, not head and neck, specifically mouth.
Thank you. Up behind first, please.
You. I was fascinated by this, well, all 3 of the talks, but the second one in particular. I know you had only a limited time, but have you ever looked at other drugs such as digoxin from foxgloves and its effect on cardiovascular problems?
No, that's a really good question. I guess something that we struggle with.
As well as also, of course, puzzling out how our ancient ancestors ever worked out what, chewing willow bark helped headaches and so on.
Yeah, I guess I've thought a bit about that as well. I guess the low-hanging fruits were easy to identify by accident, right? And so the more that we, as in the last talk, the more that we have to struggle against drug resistance and the harder it gets to identify new drugs. So we have to think up smarter ways to do it. In terms of your first question, I think one of the things that we struggle with is getting funding. So yeah, if I had more money, then I would look at more compounds. But I guess I try to prioritize things based on A, can I get it funded, and B, can I see a pathway to clinical translation before I retire, hopefully.
Thanks very much. Down here first, and then Mike in the middle, please.
Thank you. I have a question for Marcus. I was interested in the structure of ATP4. It's reminiscent of a transmembrane protein and possibly even an ion channel. Is anything known of its function?
Yeah, in fact, you're exactly right. That's a very astute comment. I should have said that, but it is a sodium transporter, and it's really crucial for the parasite. And the compounds that hit it actually kill the parasite very, very quickly. So they're one of the fastest acting modes of killing the parasite. So yeah.
Thank you.
All picked up.
So Mike in the middle there, please.
Thank you very much. 3 terrific talks, really enjoyed all of them. First of all, not a question for Marcus, but a comment. I first met Marcus several years ago at Sanger when I was dropping through, and I was so excited by the barcoding technology. And I came back to Dundee, I said, this is a guy we've got to get to move to Dundee. And he said, oh, we're already working with him. So I thought that was great. But it's so great to have you here now, Marcus, and welcome to the team. Mike, I was fascinated by your talk. The phosphorylation site 308 on AKT, you noted is obviously could be a biomarker. I mean, there are very good P308 antibodies available, monospecific antibodies available. Is that something that you could introduce as a diagnostic, maybe?
Thank you for that top tip. Yes, it's certainly something that we're looking for more avenues for us to sort of develop the research or grow from what we've found so far about the AKT pathway and its crucial involvement in oral cancer metastasis. So it's certainly an area that we would look into in the future, because we really wanted to develop biomarkers in AKT, and its pathways turned out to be actually one of the most important ones that we've discovered. So it would be interesting to start using antibodies to block the pathway and see what impact it has. At a clinical level, I think we're many, many years away from moving from purely surgical management of mouth cancer, which is the primary mainstay, to immunotherapy. But I think progress in that direction would be very beneficial for our patient cohort because of the significant impact of the surgery.
Great stuff. And just one other point, I mean, Graham says he's been using our proteomics facility extensively, which is great, but for biomarker discovery, proteomics is fantastic. And again, for Graham, we've just taken delivery of 3 of the fastest mass spectrometers ever built. And that means that we can do things cheaper than we ever could before. And for Graham, you might want to think about doing thermal proteome profiling, where you look at the thermal shift of target proteins when they bind their ligand or drug. And we can screen the melting curves of the entire proteome simultaneously and look for the 1 or 2 proteins that shift. So from a mode of action point of view, that might be something you want to talk to Dougie.
That's a really helpful comment. Thank you.
Thank you.
Thanks very much. Rory, over on this side. Is there another microphone? Yeah, Rory, up there.
Thanks. 3 really excellent talks. So a couple of questions. Mike, first of all, if it's possible, I was wondering, of course, about these factors, the risk factors for oral cancer you pointed to related to systemic or local inflammatory change. So the first question, I guess, is around vaping and whether there's any evidence that vaping does induce local inflammatory change. And I guess the other question leading on to is whether you think the vaccination program for HPV may make a difference to the incidence of oral cancers in the future.
Thank you very much. Oh, sorry.
Oh, and very quickly then after that for Graham, what's interesting is as we move to an era of precision medicine, of the right drug for the right person, what you're potentially arguing that actually there is a role of non-specific or less specific agents in the treatment of some of the common diseases like obesity and diabetes that we see available. And I just wonder what your thoughts were about that as a general approach.
I'll go first. Thank you very much. I'm glad someone asked about vaping. Vaping, as you all know, was brought in to try and get people off cigarettes for smoking cessation. But now we have a generation of very young people who've never smoked, possibly never would have smoked, who vape from a very early age for prolonged periods. And there's some work from the States showing that never smokers are now developing mouth cancer, possibly attributable to the action of vapes. And cell culture work shows that if you expose normal cells from the inside of the mouth to the liquids from vapes, they transform into malignant cell types. So certainly vaping is unfortunately going to be probably giving us a new generation of people with head and neck cancers, possibly attributable, and I think time will tell. We probably will see some evidence. There is evidence that it damages the periodontal health, so the ligament that holds the teeth in. We're seeing higher instances of gum destruction, which is an inflammatory process secondary to vaping. So certainly now there's evidence that vaping is actually quite harmful for the mouth. HPV, the work from the HPV vaccination programme that started in Australia has actually showed significant improvements in cervical cancer incidence, because cervical cancer has a high incidence of HPV involvement. It's the commonest reason people get cervical cancer. So we'll probably see, and I hope we will see, that oropharyngeal cancer rates will drop as a consequence of the UK-based HPV vaccination programme. And it looks from our work and others' work that about 25% of mouth cancers that may also benefit from the protective effect of vaccination. So I'm hoping with the passage of time we will see the incidence of HPV-associated mouth cancer and, even more importantly, oropharyngeal cancer, because up to 80% of oropharyngeal cancers are caused by HPV. So hopefully we will see a benefit in time. Thank you for that question, both questions.
Thanks very much. Are there any more questions?
Oh, no.
Oh, sorry, Graham, I didn't.
Okay, so I'll just briefly say another great question. Thanks, Rory. So I think that, well, my feeling is, but I would say that, wouldn't I, is that there is certainly a medium-term and a long-term future for these, I suppose you call them legacy drugs. But I think, and again, it's maybe self-interested, I think if we can know more about how they work, then that helps us in two ways as we go forward to precision medicine. The first way is it allows us to stratify use of those drugs in a better way. And the second thing is it also allows us to identify the really important targets and hopefully in an ideal world develop a more specific agent against those that will give us the clinical benefits without the side effects.
Apologies for cutting you off. Sorry about that. Any other questions in the room for any of our speakers? So I've got a couple of things to say before we release them from their chairs. Some of them are for all of you, and some of them are just words of thanks. But before I finish, I think the main thing to say is to offer our thanks to each of our speakers today. I think it's personally speaking, as a person who's not really technical in this kind of field at all, I'm really grateful to you for making the stuff easy to understand. Because I do think that is one of the key things that we need to be able to do in the university, is to be able to present the work that we do in a way that makes sense to people. And I think that was really very, very much appreciated. And the second thing I think I'd like to thank you for is for giving us some hope, because each of you pinpointed things that we might be able to do going forward that might lead to the either reduction or the obliteration ultimately of some of these diseases which cause so many people to be ill and indeed so many people to die. So really grateful for giving us that hope as well. So I'm just going to say a final round of applause for our speakers, and I'll release you all. Thanks very much.